So first, I want to welcome Keith Evans from Vanderbilt Life Flight. I want to welcome Dave Holloway from the Cleveland Clinic Critical Care Transport team, as well as I think Tanner Pernhagen will be joining from that team. I see Robert Grabowski is on. He has worked for Metro Life Flight, as well as now Children's Nebraska Critical Care Transport. I don't know if James Rutherford is going to join or not, but he's the NP manager at Metro Life Flight. And then Jacob Miller, who was a nurse practitioner who flew for Air Care, Cincinnati Air Care, who at one time used nurse practitioners, but now they do not. And then really the reason I want to welcome my students who are who all desire to be nurse practitioners in this, in critical care transport. So Lanika Tucker, Henry, I've never asked you how to say your last name, but Henry, I'm going to say Dusharer. And then
You share close enough.
Okay. And then Raquel. And then there's some other guests on here that I welcome all of you. But one of the reasons that I got this panel together, and as well as did a YouTube series last year, was I teach a program at Case Western Reserve University that tries to prepare students and educate students about the role of NPs in critical care transport. And one of the things that became obvious to me once I started doing this was my opinions are just my opinions, and the role is very small nationally. So I reached out to people I knew and tried to find other teams who use NPs. And I put together this series of kind of informational videos on what these teams are doing, because there's no book for me to give students. There's very little published literature about this topic we're going to talk about. So all we really have are kind of anecdotal things and kind of listening to people on what they're doing. So I will tell you, Dave, Keith, Jacob, and Robert, the students here all have listened to these videos, and really that was one of the assignments. We listened to the videos, we watched them, and then we talked about them and discussed them. And the goals of getting you guys back together again, my big overarching goal is, I think next year or in the upcoming years, I want to present about this at AMTC or national conferences to kind of share this literature and kind of share this knowledge that I have kind of on the topic. So I want to make sure that kind of what we're going to talk about is accurate. And then I'm going to go back and listen to these videos and kind of present how I feel I can about this topic. I want to highlight best practices and common pitfalls for nurse practitioners in critical care transport. I'm going to share innovative insights related to NPs and CCT. And then I also want to give my students and then anybody in this audience a chance to ask you guys questions. So the chat will be open. And I don't want to go through everybody, but Henry, Raquel, and Lanika, if you can quickly introduce yourself. I'm talking a minute or less, then I'll kind of get into the presentation.
You go first if you'd like, Dr. Kanicki.
Sure. And then kind of explain to them your goals really quick as far as where you want to work when you're done.
All right. My name's Raquel Doak. I am currently an adult gero-acute care nurse practitioner student at Case. And I
I know
have
from the
just
domain meeting, one of the big pieces of understanding is just what, almost like a roadmap of what it looks like to implement.
okay. Am I all right to talk?
Yeah, you're okay. Go ahead.
Okay.
Guys, if
All
you'll
right.
be diligent and make sure if you're not speaking, you're muted. Go ahead.
All right, so adult gero acute care NP student currently at Case. I've completed my peds acute care at Case as well, and currently working kind of as needed as in metros, make main ED, and as well as inpatient hospitalist pediatric at Fairview. Um, and my goal is to probably more the trauma side of flying, but to provide care in that setting.
Thanks, Raquel. Henry, you want to go next?
Yeah, sure. I'm currently the PI coordinator for the trauma team at Cleveland Medical Center, UH. But my background's in ICU, ED, and worked for Mercy Life Flight as well. I'm currently a acute care student at Kent. Got about a year left on that, and then I mean, up in an ideal world, I'd convince UH to fly NPs and do that, but that's a ways out, I think. Not really sure 100% where I'm going to work when I'm done, though.
Thanks, Henry. And then Lanika. So I can tell you about Lanika. So she's out in San Diego. She's a flight nurse, and she's also she's a practicing acute care nurse practitioner in the neuro ICU. So we really have a pretty good group. So Henry has flight nurse experience. Lanika is a flight nurse and practicing ACNP. And then Raquel is dual, so she will be dual certified pediatric ACNP and adult ACNP. So Keith, I'm going to start with you. I sent you guys this slide. Can you tell us about yourself and about your program? You don't have to get into all the details that we did before. And then also make sure kind of what I have here is correct. In particular, I think one of the big things that stood out about your program was the fact that you fly both FNPs and ACNPs. But can you tell the group about your program?
Sure, would love to. Thanks again, David, for getting all this together. So a couple things about our program is, so we started back in roughly about 2018 discussing how could we implement, we have a lot of our flight nurses that had gone back to school and either done the ACNP or FNP, and how could we go about getting them credentialed through the emergency department and allow them to actually practice as NPs on our aircraft. So a lot of discussion with upper leadership within the hospital as well as the emergency department. And we got buy-in from our Office of Advanced Practice. We got buy-in from the upper leadership within the institution as well as the emergency department. And so we went about that route of looking and saying, okay, what would separate us that we're doing now versus what we would be able to do as an NP? So some of the things that has separated it is our ability to act as our own medical control in situations. That's a huge one. The other thing is that we were allowed to deviate from our standard protocols as long as, you know, it fell within our scope of practice. Now, with that being said, that kind of where medical control kind of falls through. We do have certain procedures or policies that say, hey, you've got to reach out to medical control before you can do that. However, if you're a practicing credentialed nurse practitioner on the aircraft, you were able to do that without having to call back and talk to our medical control if you felt that that was what was needed in the best interest of the patient. So we also added additional scope of procedures that we were allowed to do. So we brought people in, had them basically get privileged to be able to do these procedures. And then a couple other nuances that we added to this was one, recently, as of January 1, all of our NPs had taken that were eligible took the ENP exam. So some people like myself had gone when I did my postmasters as an FNP. I also added ENP to it, but those that have been practicing for the last few years were able to sit and successfully take the ENP exam. So now all of our eligible NPs are FNP ENPs, or we just have ACNPs. Now, the difference between what our ACNPs are able to do versus our FNP ENPs are able to do is they're able to take care of the patients as a nurse practitioner up to the age of, in our state, it really says around 13 to 16. They just say adolescents. So they don't really give an age on it. So we've kind of defined it as 13 or greater. They can manage the patient as a practitioner. If they're less than that age, then they will fall back and utilize their resources as a registered nurse. So that's one of the nuances for our acute care side of the house. But for their FNPs, ENPs, they're able to do from birth forward. So that's one of our things. Another thing that we have recently been able to accomplish, and we're still in the process of developing it out for all of our providers, are we're in the process of making them all billing providers. So we have successfully been able to work through our process using Epic, using EMS charts, documenting, and being able to bill for critical care time as long as we met the metrics. So we have been able to successfully do that with some test pilots, and we have been able to be reimbursed. So moving forward, we're going to all start transitioning them to billing providers, and that we can bill for our critical care time. Now, they still fall in that global period for the global transport, but the individual will be able to bill under their NPI and be able to bill for their critical care time. So a little backstory on me. I know this is kind of out of whack. So I started flying with our program roughly about 20 years ago. And before that, I was a flight nurse in the military, and went back to practitioner school. I was originally started out as acute care. So I did ACNP, and then went back and did a postmaster's FNP, ENP. And I had started out as a flight nurse, then I moved to a chief flight nurse, and then I moved more into an administration role, and was really able to, with all of my colleagues, help push this through. So it has been a great thing. Currently, we're sitting at around 27 NPs, and we are looking to add a couple more. So I think by the end of the year, we'll be sitting at around 30 NPs throughout our transport. And we also cover air and critical care ground. So currently we've got one critical care ground NP, and we're looking to add a second to our critical care ground team. So that's kind of it in a nutshell. There are a lot of other nuances, and nuances is probably not the best word. There are a lot of other intricate things that our NPs are involved with. We have a shift operations center, which is basically part of our transfer center, and they kind of oversee all of the transports, all of the people coming in, and they are the ones that provide acceptance. So rather than having the referring facility have to talk to the triage physician and get acceptance, when they call the transfer center, they switch them over to our SOC nurse practitioner. They listen to the report, providing the advice that's needed, and they accept the patient on behalf of the ER physician that's in triage, and then they get admitted to the hospital. So that speeds up the acceptance process. It also speeds up the transfer process and prevents the triage physician that's actually working down in triage, taking care of patients, from having to stop what he's doing, answer the phone, or leave the referring physician on hold for an extended period of time. So, excuse me. We've got a lot of other things that we're going to be involved with moving forward. There's constantly newer things on the horizon as they recognize our NPs are more and more capable of doing other things. So a few things that we're working on now is also, and this is going to happen in the future, we're not doing it now, but anytime that there is a medical control, we're working on their medical control workflow. So anytime that medical control from that aircraft comes through, we're going to utilize our SOCs to act as their medical control so they don't tie up the physicians in the emergency department. So that's going to be a big help. And they're also going to help facilitate if they need a specialty physician that they need to talk with, whether it be OB, cardiac, neuro, any specialty, toxicology, that they'll be able to communicate directly with them and act as the go-between and make sure that they are communicating effectively and getting out right orders or anything that is needed to help our crew members ensure that they are getting the timely response as well as the accurate information.
Got it. I think I'm going to move to introduce the other three, and then I see this going well as you guys just talking shop. I'm going to kind of guide that with like questions, but like Keith, if you have a question on how Dave does things at the clinic, or Robert, or vice versa, then we'll just kind of open it up. But Dave, can you kind of give an overview of the Cleveland Clinic, and then we'll go from there?
Sure, that's fine. So thanks again for inviting me and putting this group together. So we started using NPs on our transport program back in 2007, 2008 or so. We currently have about 16 NPs, and that's kind of a mixture of some of our admin team and also some individuals who do transport full-time. And we have two other NPs who work full-time in our EICU center, but they are part of our department. So we use the NPs primarily on rotor, and they also do some coverage in our EICU center about, I would say, 15 to 20% of the time. And the rest of the time is spent on our aircraft. We also staff our fixed wing program with an NP model. So our NPs take varying amounts of call throughout a scheduling period. And they either, if they're called in, it's either to cover a fixed wing or to cover potentially a call off in a jeopardy situation to keep the aircraft staffed. We also use the NPs in a med control role for our mobile ICU ground units who may be calling for med control. We're the frontline providers of those calls, which again, I think as Keith kind of mentioned, frees up the physicians to focus on other duties. We use exclusively acute care NPs. Part of the reason for that is years ago in Ohio, our prescribing formulary was tied to your certification preparation. So there were certain things that acute care NPs could write for that, an adult NP or a family NP couldn't write for. So that was part of the rationale for using acute care NPs only. We don't require dual certification for adults and peds. In our program, age 14 and above is able to be managed as a provider, and then 13 and below, you function as a registered nurse and would follow a med control process to manage those patients. However, our pediatric volume is exceedingly low, and we have a dedicated peds neonatal specialty team that handles the majority of our pediatric transports. We do bill for our services. We bill critical care time, but also for procedures if certain criteria are met. Excuse me, and all of our providers are billing providers. I think that's a kind of a high-level overview of our program.
Yeah, I agree. Robert, since you have, I don't see James here. So if you can give just an overview of how NPs are used at Children's, because you're just starting that and kind of how that went. And then either you or I could talk about Metro Life Flight. So I'll let you go.
Sounds good. Yeah, so my name's Rob Grabowski. I'm dual boarded adult acute care and peds acute care. Just recently, within the last 9-10 months, went out to Omaha, Nebraska to help critical care transport program at Children's Nebraska kind of really solidify the APP model. They're a specialty team, peds neo, no high risk delivery or anything like that, just peds and neo. But they're the only tertiary and only specialty peds hospital within the state of Nebraska, as well as covering Western Iowa, Southern South Dakota, Northern Kansas. So really large catchment area. This is just the second year of utilizing both PNPs and neonatal NPs for their team. So we have, one team, so to speak, but two different service lines almost, with one being the neonatal team, which is 24-hour coverage a day of an NNP and RN, both of which are completely owned by the transport department, not, shared NICU or anything like that. They're all trained in full-time transport team members. And then 36 hours a day of pediatric CCT coverage, which is the goal is a PNP and RN or PNP and medic. However, just with staffing challenges and we're trying to grow at the same time, we're still also doing RN style transports as well. One of the unique things, I guess, about the program out there is they don't assign teams to assets. They have, kind of the staffing of the day, and then, the crews get made up based on the calls and then take the asset that's most appropriate to it. So the NPs do fly, they do ground, they do, rotor and fixed and do ground. And then it just kind of, triages and utilizes their resources as best they can. It's a I was a big advocate of the NP model, obviously, even, in Ohio, where we have a lot of tertiary centers pretty readily available. Moving out to Omaha and helping with this model out here has really solidified a lot of those benefits for me. And honestly, this is like just exponentially more beneficial to patients out here because especially when you start talking about critical care peds and neos, 90% of the population lives in the city of Omaha. So essentially anything west of here is a critical access hospital that might be staffed by 2 nurses for the whole hospital. And the likelihood of them being up to date on peds crit care or neonatology is slim. So to be able to send that advanced practice provider out to the patient, 3 hours into rural Nebraska, and help resuscitate, a extreme prematurity neo or, a sick pediatric patient it's been amazing. So, so that's where I'm at with children's. I was at Metro Life Flight for the 12 years before that. I was their chief flight nurse practitioner before I left to be the manager over at Children's. Similar model to Keith and Dave, where it's a adult acute care nurse practitioner and RN team matrix. The NPs almost primarily flew rotor. We didn't do fixed wing at Metro. NPs could work around, but often didn't. It was mostly a nurse medic or nurse medic EMT configuration. For Metro, we started billing as billing providers. In the end, I think we found it a more beneficial model to have an augmented base rate. We had less denials and a more streamlined and efficient billing process that way. I'm happy to have a discussion about that as I'm working through the complexities of whether or not to bill my NNPs and PNPs out here versus doing an augmented base rate again. So happy to talk about that, but I know that's sensitive information. So if we don't want to talk about that, we don't have to. But as you mentioned on the slides here, yeah, we also did residents at Lifelight. They were 3rd-year EM residents, so almost attendings. So they are getting ready to branch out on their own. They were crew members, primary crew members, so they came out and received a 1-day training, or I'm sorry, 2 days of training by the end. And then they were the primary crew member with an RN partner. And most of the time they were trained by NPs or a handful of moonlighting attendings. So it was really nice to have the ACNPs be a primary stakeholder in physician education, particularly around critical care transport, and some of the logistics, political components and financial components. And I think it really helped augment their education as when they left as attendings into the community ED practices of what really goes into those calls. And we had the same stipulations, 14 and above. Under that, the ACNP would revert to an RN and have to call unless you were dual boarded. We didn't really have a ton of extra components like, we don't have an EICU or anything that we would do. For a brief period, we were part of the CMS ET3 study. So the NPs were eligible to take calls from EMS providers and provide medical direction online for alternative destinations as well as treat in place and those kinds of things. So that was a nice stretch of their legs as far as experimenting with some new and unique models for how Lifelight and EMS and CCT NPs could really get involved in EMS management. And then looking at your list, I think it's about, oh, and one of the nice things we did at Lifelight, was to leverage some of the NP autonomy. So we provided tactical EMS and operational EMS services for the U.S. Marshal Service, for the Violent Fugitive Task Force, as well as some training for the FBI and county sheriff's departments and things like that. We often would utilize some of our RNs and medics in some of those roles, or would have liked to continue to do that. However, with some of the stipulations through the nursing chain of the hospital, there were some challenges there. And the fact that we could send our NPs and they would be autonomous and not require, a medical director, so to speak, to back them up. That was a nice perk that, our NPs got to go pick up shifts as, operational medicine specialists with, the U.S. Marshals and other government agencies. So, yeah, that's about what I got.
Thanks, Robert. We will get into billing. And again, nobody has to give away details, but this is one of the fundamental issues and the biggest challenge that I have when people ask me that, because the question always is, well, NPs want to make more money, but how do we pay for that? So we'll get into that, not heavy, but we can discuss it. I think it's a really good topic to discuss. Before I move on, I want to give credit where credit is due. So Lanika was the student who came up with this chart. She listened to all the videos and then she kind of put her summation there. So I don't want to take credit for this chart. I think I edited it a little bit, but most of this is Lanika's work. Jacob, if you'll kind of talk about your background at Air Care, and then I guess in particular, why you think things didn't work out, and then we'll kind of move on to, and we'll just make this more of a discussion about particular topics. Go ahead.
Yeah, absolutely. So, I mean, first and foremost, I think that was discussed quite widely on our previous video series or webinar series. So I certainly encourage folks to review those recordings. But I think one of the things that I'm hearing from several of my colleagues here is that there's multiple different roles for the nurse practitioner that can help to augment the overall performance of the transport system, whether that's triage, medical direction, medical oversight in some capacity. Certainly, obviously EMS systems are overseen by a physician medical director or physician medical directors. And at no point are we implying that a nurse practitioner should be replacing the physician medical director. But I think there's a lot of things, and especially those of us who work in larger EMS systems, whether that's a flight program, ground critical care, or any other permutation thereof, or just even a large, busy 911 EMS system. there are a number of different things that is tasked to the physician medical direction team that a nurse practitioner can assist with. And I think one of the challenges that we had at my program in Cincinnati is that the nurse practitioners were very much just treated as a staff member that would work on the aircraft. There was no formal additional role, responsibility, added value, and really what we look at is, I think one of the challenges is looking at not necessarily what you do when you're out on a flight, but perhaps some of the added value that the nurse practitioner can bring during some of that non-productive time. It's probably not a secret to anyone who's on this webinar right now or listening to the subsequent recording that nurse practitioners, or I'm sorry, the flight teams, whether it's a nurse practitioner, a nurse, a paramedic, a physician, a respiratory therapist, whatever the crew configuration is, that team is not working 100% of the time, right? There's going to be downtime in between the actual patient transports and other mission critical aspects of that person's day. So I think one of the challenges that we ran into when the health system as a whole was looking at ways to cut costs and recover some of the revenue that was sort of decimated during the entire COVID pandemic was, they looked at where is there a substantial cost without a, equivocal or equivalent gain. And one of the things that rose to the radar, whether, good, bad, or indifferently, was our transport program. Now, it's not the case that the hospital system decided, well, we're just going to get rid of the NPs. This was part of a larger cost-saving initiative that came down from the health system that also included cutting 24 hours of service out of our day on the air side. So previously, our flight program operated 3 aircraft 24/7. And so, effectively, what is that, 72 hours of coverage per day. And then one of the directives was the program was going to go from a 72-hour of operation per day down to 48 hours of operation per day. So that was one of the major cost savings, was just eliminating 24 hours of air coverage each day. So downstaffing not only the nurse practitioners, but also downstaffing some of our nurses, downstaffing some of our pilots. I'm not sure exactly what the mechanic side of things ended up looking at, but working with our aeronautical vendor that holds the Part 135 to make sure that those costs were contained and looking at that. And then as sort of collateral damage from that, they also said, well, we're cutting all these hours and we're basically don't have room for the nurse practitioners to regularly appear on the aircraft. And some of us had pushed back actually and came up with basically a counter proposal to say, well, here's what we're willing to do, because we recognize the value add of the nurse practitioner or just advanced practice provider model, whether that's NPs, PAs, physicians on the aircraft. And we proposed effectively a way to sort of cover that remaining hole in the schedule with what would effectively be PRN flight nurse practitioners. And because it's really hard to guarantee staffing with the PRN only model, it was of course declined by the health system. To be clear, the hospital does still operate with residents on the aircraft, but because of ACGME restrictions, there's only so many hours that they're able to put in and only so many residents they're able to staff in any given period. So, of our 48 hours of coverage per day, on average, 36 hours is covered by a resident, and we work 12-hour shifts. So 3 of the 4 shifts in any given day are covered with a resident and a registered nurse, and then the remaining 1 shift is now covered with 2 registered nurses. There are now 3 of the former flight nurse practitioners, myself and 2 of my colleagues, that are flying with the Air Care program. Currently all in a PRN capacity, but we're all flying as nurses. And coming up in a few weeks, I'm going to make a transition back into the flight program on a full-time basis, but it's going to be full-time as a flight RN and not as a flight nurse practitioner. So, some of the things that that would limit, obviously, is exactly what Keith, Dave, and Rob were talking about, is the ability to step out of protocol, the ability to function as that medical control authority, the ability to there are some advanced procedures that are still restricted to a provider only within our protocols. Some of them that are kind of, we're still working on trying to figure out how to get them given to the nurses, because they are well within a registered nurse's scope of practice in the states that we operate. For example, arterial line placement. There's nothing that says a registered nurse can't do that. And there's other things that probably should never be given to a registered nurse, like a perimortem hysterotomy that is quite clearly, an invasive surgical procedure. So I think that, those are my thoughts. And obviously I wasn't part of the leadership team when these decisions were made. I was just sort of the, one of the end users. But, having a doctoral degree, having my master's in business, and kind of looking at what was happening, I think that really, one of the major contributing factors to our program not being successful was that failure to account for some of the non-productive time and failure to integrate those nurse practitioners from the start into other key aspects of the program's operations. You've heard from other folks about getting the nurse practitioners involved in staffing other units in the hospital, whether that's an e-hospital and Cleveland Clinic's standpoint, or other clinical appointments. You've heard about taking medical control and freeing up some of the task of the the ED or the program physicians. You've heard about some of the other aspects, and I think that that's really one of the keys in looking at implementing one of these models, especially if the nurse practitioners are going to make any more money than a registered nurse. Certainly, I think if there's a difference to be said if you were to take a nurse practitioner, credential them to perform at a higher level, but don't reimburse them anymore. Well, now you don't have, there's some overhead cost that's going to increase, obviously, with a very small incremental cost, I'm sure, but still, there's going to be an increased cost for your malpractice insurance and other regulatory things behind the scenes, especially if the hospital decides to pick up your DEA license or whatever the case may be. But
yes, I'm going to interrupt Jacob, because I think this is a good point. One of the things, if we want a lot of opportunity for NPs, I think you bring a higher level of care and you need to get compensated for that higher level of care. I think that it's unfortunate that ACNPs practice at a high level and they come in as an RN and still offer those teams that high level of care. Keith, Dave, and Robert, I guess if you could sell this in a sentence or 2 or 3, how would you sell the NP model to like administrators? Like, what are the biggest benefits that you feel make up the cost?
I'm going to say one of the ways that we were able to, I hate to use the term sell, but we were able to show value add was, one, our institution is very nurse practitioner heavy, and that we have a school of nursing that is associated with Vanderbilt University Medical Center. So they recognize from the physician standpoint how important nurse practitioners are, but also we have a lot of medical services that, whether it be ground or air, that operate within our same geographic region. And the level of care that we were able to provide, we knew the hospital, we knew the protocols, we knew we've worked hand in hand with these physicians and say, hey, we can better present the patient to you in the emergency department or the ICU, wherever they're being transferred to, because we're able to utilize our resources as nurse practitioners. and kind of step outside of some of the standard protocols because we have been trained. You've worked side by side with us as NPs and seen how our level of clinical expertise is, and they were very supportive of that. So the institution as a whole was very supportive of advanced practice providers because that essentially is what keeps our institution going. So I think that was a I tailored on that when we were presenting all this to upper leadership, and they saw the value add.
I agree 1,000%. I think the level of care, it's a whole nother level. And I know some RNs and paramedics may give pushback to that, but it's not like 20 years ago where the senior flight nurse had all this experience. You know, you're facing the minimum 3 years of RN experience, and we all know that experience is what matters. And to me, it's a whole nother level of care, and it's not that much more money. Dave, Robert, any comments on, like, if you had to sum this up in a couple, sentences, what do you think the value add is for the NP model?
Sure. So I would echo basically what Keith just said. I think we also are fortunate to have an NP heavy practice model at our institution, which garners that physician buy-in. I think another thing that helps us sell this is that, certainly for some patient populations, you can write a protocol or a guideline, and a non-provider could follow that and probably give some decent care. But when you're talking about some really, really complex patients, kind of those high-end critical care patients, it is next to impossible to write a guideline or protocol that somebody can follow like a cookbook. So from our standpoint, we would say, if you wouldn't give a nurse in the ICU this cookbook to follow, why would we give this cookbook to somebody who is transporting those patients? So we get buy-in from our institution because we can say we're giving patient-specific orders that avoids the need for protocol-based care. So that plus everything else that Keith already mentioned is really how we continue to sell this in our corner of the.
How about you, Robert?
Yeah,
I
I think it depends on your audience, right? So knowing the pain points of your organization will really help you sell that and kind of tailor your response accordingly. Because yeah, there's a ton of benefits, but not all benefits are going to be as beneficial to every organization, if that makes sense. So like the typicals are, you're going to highlight the cost benefit of, hey, this is 1.5 times the normal FTE cost for nursing, but I can generate that in billing. And so that's a wash or a gain or whatever. I usually try to leverage like risk liability, clinical quality, and a lot of organizations struggle with throughput. So like my organization right now, if I can send a PNP out to the bedside and truly evaluate that patient as a provider and can prevent them from going to the ED and adding to their ED stack up or boarding them, like finding the true destination, or maybe I can, say ICU bedtime is a challenge in your organization, and we can provide numbers that shows, hey, when I show or send this PNP out 4 hours into rural Nebraska, and they resuscitate this kid for the next 3 hours on the way back, maybe they don't need to go to the ICU anymore. Maybe we can decrease our internal costs and not necessarily just, am I billing what my FTE coverage is, but what's the financial impact to the organization? And, through the other myriad of mechanisms of, other things we can help out with. But, clinical quality, risk, throughput, those kinds of things I tend to focus on. I find that particularly nursing leadership, for whatever reason, really enjoys stories. It's probably the whole magnet thing. So if you can give good clinical stories, like, you know, we were talking to our magnet appraisers or somebody the other day, and we were talking about the story of, you know, we had this extreme prematurity infant that was born in rural Nebraska, and you know, we sent our NNP out there who's got, you know, 12 years of delivery experience and all this stuff. And not to say that our NICU nurses aren't amazing at what they do, they really are, but just clinical experience as a provider to make the decision. You know, she went through all the resuscitation processes and determined, hey, this kid's not going to make it. We don't need to relocate them 4 hours away from their home. We can do compassionate care here. And that's a really burdensome thing to put on someone, especially if they don't have a level of experience to match that. So I think there's a ton of, you know, benefits in, you know, someone who has credentialed in procedures and has that experience and understands the clinical continuum of care, but also when to de-escalate and to make those burdensome choices of, I'll own this because I know this is what's right. And to Dave's point, like, you can't put that in a protocol. You know, certainly you can have end of resuscitation goals, or, you know, this isn't going the right direction, but those don't fit a lot of patients. And to really provide that bespoke tertiary level care at the bedside of the patient, you have to, you just have to send an experienced provider out to see them. And you mentioned, you know, some nurses and medics providing some pushback, and it's true. Like, I've had to, you know, kind of deliver the news of the NP model to a couple different programs now, and it's never really gone over well to, you know, the nurse medic staff, because it kind of alienates them and it makes them feel as though, you know, you're saying that they can't perform the job that they're already performing, or it's hard to not have that emotional reaction to it. But what I struggle with as a hiring manager is, it's just like certification, right? Certification doesn't mean that one person is better than the other. It gives me a guaranteed minimum standard. So are there nurses and medics who have been doing this job for 20 years that could out clinician a 2-year-old NP? 100%, they're out there. Can I guarantee that from a piece of paper when I go to hire you? No, I cannot. And it's really hard for me to write protocols and policies and processes based on individualized human performance. I need to be able to guarantee a minimum standard. And so having that staffing model where this elevated, like, essentially, you know, advanced RN or practice, you know, APRN stuff, it's in the title, it's in the training, it's in the certification, that I'm guaranteed to get this from this individual, versus, you know, like you said, trying to find those super experienced flight nurses that have been around forever. And like you mentioned, they're not there. This isn't 20 years of, I can't say 20, but 15 years ago, where we had a stack of 20 resumes of 10-year-old plus nurses waiting for one seat. You know, most organizations are looking at the 3 to 5 year minimum to get people in, and they're still having trouble staffing. So you can't say that you're always going to have that guaranteed minimum acceptable level of, you know, advanced practice, unless you
Yeah,
I want to say
that's,
that
go
one,
ahead, Keith.
one thing that we have done, and that in going along with what Robert said, is we don't hire directly into the NP role. We hire you in as a RN, and then you've got your 1-year orientation, and then we evaluate from there to determine, are you meeting the standards that we have set forth to be a practitioner on the aircraft. So everybody gets hired in as a RN. They fly for 1 year, and then if they have met all the metrics and we see that they are a very competent practitioner, then we'll put them through the process to get credentialed and privileged. But that was one of our fail safes, because, again, to Robert's point, we have some very talented flight paramedics, flight registered nurses, and hiring a new NP straight into that role, these very talented ones are going to run circles around them because they've been with programs or been with our program for years. So we want to make sure that we are getting the level of experience that is expected within our program.
Yeah, I agree. Dave, do you have any more comments? I think we kind of covered them. Guys, I'm working on enabling the video. I didn't know it was disabled until Tanner just texted me. So I'll work on that.
No, I don't have anything further. I would agree with everything that everyone else has already said. And would also just kind of echo what Robert said about, sometimes difficult decisions need to be made, and that kind of whole package that an experienced, nurse practitioner brings is really invaluable, and can certainly help get a transport crew out of a bad situation, and while simultaneously doing the right thing for the patient, which often has some downstream benefits. So that's all I would add there.
Yeah, and I agree with everybody too. I mean, looking at what that justification is, and looking also at what's published in the literature, I think now there's also resources that a program looking to implement this model can bring. Dave, you and Rob and Dave and Abby and Lisa had published the document I think last year in AMJ about the role of considerations for the transport critical care nurse practitioner. The NAEMSP has a position statement on the utility of advanced practice providers in EMS systems. The national AAENP has a position statement on the role of nurse practitioners specifically in EMS systems. And really all of those documents say the same thing, where there's a number of different benefits, and not that you have to use all of them, but use enough so that you can justify that practitioners presence on your team, in your program, at your system, and see how that can work to justify some of the added expense. When I said that they could be paid as a nurse, I wasn't advocating for that. I certainly agree that they should be compensated as an advanced practice provider, but now you have to figure out how to fill that deficit between, I could hire a nurse at X or I could hire an NP at Y, and somewhere between there is a difference in cost. But I do agree with what everybody has been saying, like all these other things that you can add into the system could be able to substantially make up for a lot of that difference, and that's what needs to be sold to the more bean counter mentality, analytic folks. Stories are great for nursing, totally agree, but also at the end of the day, someone is going to have to account for the money that you're looking at, and being able to say, like, these are all the different ways that we can benefit the system, I think is absolutely important. And again, fortunately, we have a lot of resources that are now, out there in publication that I think, Dave, between you or me or whoever, we can refer people to if they're interested.
One of the things, David, that we also used to go along with what Jacob said was our nurse practitioners took on a large portion of, they have their own trauma service. So they come off of the trauma ICU and then they go to the trauma NP service. And they did a study and they were able to show that the utilization of nurse practitioners reduced their hospital stay days by 1.3. So we use that as a leverage to say, hey, if we're utilizing NPs in transport, we're already starting to think, at point, even though we're picking them up at a scene or a hospital, we're already thinking about discharge stuff. So what are the things that we can implement here to reduce the hospital stay days? It's already been proven that NPs have reduced it. And so that was another thing that we added to that leverage to say, hey, here's an advantage, and here's to use their term, bean counters for a numerical advantage of, hey, if you can reduce hospital stays by 1.3, we already know that that's effective. So how much is that able to help with us being able to take in more patients, but also being able to discharge them faster, and therefore they're not sitting here lingering. And so we utilize some of that, and that actually helped play into our favor as well.
Yeah, I'm glad the video is now on. I'm sorry for, I didn't know I disabled that. This slide was also on Lanika. I'm just going to like summarize it really quick. If there's anything that anybody disagrees with, let me know. Nobody here has a hard time staffing the NP, hiring a flight NP. Is that correct? Like the attrition, we're talking very low.
I'll push back on that. Just in my new role, I'm having challenges in Nebraska, but I think that's more population density of a specialty group. You know, in Ohio, you have a ton of schools, and you've got a ton of ACNPs getting pushed out all the time. In Omaha, I mean, there's only one peds tertiary hospital. There's only one or two programs. So finding experienced NPs is challenging for me. Because there's not a ton of new ones entering the field, and when they do, they either don't have transport experience or don't desire that role. And then trying to get people to move to Omaha, Nebraska has proved to be challenging for the experienced providers that are interested. So I do have a lot of like locum providers. Like my NEO team is completely full, but we are utilizing a lot of travelers right now.
Keith, it was very interesting to me, and I've asked my students, would you go work for a flight team making less money for a year, knowing that would transition you to a flight NP job? And unanimously, they've said yes. So that's a pretty good idea that I hadn't thought of before hearing that from your team. But it's good for you too, because you can see if they're a good fit.
Absolutely. And, when we've hired individuals, they've said, I came to the program because I've been a practicing NP. However, I'm willing to just fly as a registered nurse, learn the nuances of the Vanderbilt system, learn the nuances of your flight program, and then do all the things that they need to get through that process, show that they are a value add. Not that we, I hate to use that term value add like they're not, but show us that, hey, I'm willing to take that next step because I am thinking not just they need an IV, so let's start an IV, or they need an ultrasound, let's do it. But they're thinking, 2-3 steps ahead, kind of like that chess. And we've been very successful using that model.
Yeah. I try to drive home 2 points to students that come through here. Number one, if you don't have experience as either an RN or an ICU, in my opinion, you're unlikely to get hired because you really need to add value. You have to add value, in my opinion, above what a flight nurse on the flight line would do. And then number two, as an NP, I was guilty of not wanting to do other things. I just wanted to be a master clinician. That's good, but it might not be a long-term plan. So I think what I've seen is unanimously these programs are using NPs way beyond just the clinical. The clinical component is important, but beyond that, you have to be willing and ready to do other things off of the flight line. Which was the program that used NPs as the rapid response teams? I couldn't really remember that. Is that your program, Keith?
So we use NPs on a rapid response team. We have some of our flight crew members that pick up extra doing that. It's not their primary role, but they do that as an additional. So it is strictly run by NPs. So our whole rapid response team is run by nothing but nurse practitioners.
Gotcha. And then it's the Cleveland Clinic who kind of has, I thought, I mean, this is another great idea where NPs, I don't think they like doing this, Dave, but some of the NPs will actually staff the telehealth, so help like make critical care decisions for the remote hospitals. Is that essentially it in a nutshell? Dave?
Sorry, I had to rejoin for a second. I missed the first part of that. What was the question?
I thought basically I can imagine a lot of the flight NPs do not want to do the tele ICU, but I see it as a huge value add to the hospital. You have this master clinician who's kind of a jack of all trades, kind of helping an NP in an ICU somewhere who might be all alone and overwhelmed. That was essentially it.
To an extent, sure. So there's really kind of two benefits here. In an ideal world, we would really like to have the NPs functioning boots on the ground in a clinical role for at least a portion of their FTE. We really haven't been able to work out the logistics of that despite numerous attempts. So covering the EICU was kind of a compromise. One, it's only night shift currently, so that was somewhat unpopular. And at the time, we were one of the few groups that covered night shift. So we were kind of an easy staffing option. The benefit to us was that it gives our NPs some exposure to the inpatient world without actually being boots on the ground. There is some benefit to our clinicians being able to support our regional hospitals. And then there is some benefit to us where we are working closely with an intensivist overnight who is sitting right next to us. So we can get some of that academic exposure that you would normally get during, ICU rounds or whatever. We're just getting it in a different way.
Got it. Just so everybody's aware, I have an alarm planning to end this around 1. Dave, Keith, or Robert, do you have any questions you want to ask each other? And then if anybody has to sign out, I understand as well. If you don't, then I'm going to kind of let the students ask you guys questions.
I know there was a question in the chat for me that asked how we utilize our NP on our ground team, and does that affect the flight side? So our ground critical care team, we usually run one truck in the morning, one mid truck, and then one evening truck. So currently our NP works on the morning truck. So it doesn't necessarily affect the utilization of rotor. However, what it does do is bring them that additional knowledge and additional skill set to the bedside. So when the request comes in, they have to look at geography. What is the closest aircraft available? Or does this meet ground? Is this better utilization of the ground critical care? And I'll use ECMO as an example. Our NPs will go on the ECMO transports on the ground, whereas it's more difficult unless we're going to utilize them on a fixed wing. It's very difficult for us to put them into our rotor wing. So we've utilized our ground crew with our nurse practitioners to do more of like the ECMO type components. They also play a huge role when we're down for weather, right? So we're in the South, we get hit with tornadoes, it seems like every other week. So we can utilize our rotor wing crew, but the problem being that there may not have ground transport rapidly available to get to our crew. So our nurse practitioners help out with that as well.
And I'll add to that. We only have one nurse practitioner on the ground side. And to your point earlier, David, about being involved in other ways besides just the delivery of patient care, She is critical to the education and the ongoing skill and growth of that critical care ground team. And her knowledge and training as a nurse practitioner has made a huge difference in the education of that group.
Excellent, thank you.
Yeah, let me make sure I'm not missing any other questions. All right, so I get asked by some of my students kind of where they should go after school. And my advice to them is always to go to the ICU and go somewhere where you'd be practicing at a high level, including intubation, central lines, arterial lines. What are your thoughts on that? Like coming straight out of a program, very little experience, but ICU experience, or an ICU NP who is already a practicing NP?
I mean, I agree. I think you necessarily have to have that, and maybe not. But I think that there's a huge learning curve and potentially a huge disadvantage to an individual who, maybe they have experience as a flight RN for example, and or a paramedic or whatever, and they're a brand new baby nurse practitioner and they get put immediately onto the flight line. Is it possible to do that? Absolutely. It's basically my background. That's my backstory. So my very first acute care NP position was with Cleveland Clinic CCT. But I also recognize, looking at the performance and the caliber of some of my colleagues, that, obviously there was a disadvantage there. I was also that flight nurse that started flying as a flight nurse, not having done any ICU time and only having been an emergency department nurse and paramedic before I started flying. So it definitely is possible. I would like to think that, by and large, my career has been successful so far, present setback excluded. But I think that there is definitely a benefit to having that time as a practicing clinician, an ICU nurse before becoming a flight nurse, a practicing critical care nurse practitioner before becoming a flight nurse practitioner. Unless there is another way to make up for that. For example, maybe you do a shared FTE between inpatient and, through inpatient. I think the e-hospital, I agree with Dave Holloway's remarks earlier. It is a way to get exposure to inpatient, but I do agree, and I think that he and most of the team there would probably agree that it still would be better to have the boots on the ground, as he said, experience in an ICU, because even something as simple as procedural skills. How often do I do an echo in the ICU versus how often am I going to do on transport? How often do I place a line or intubate somebody in the ICU versus doing that in transport? So it's a good way to keep up your clinical acumen, but also your technical skills that we know you have to have some degree of exposure to and experience with on a regular basis to remain absolutely proficient, so that now you can do that exact same skill in the back of a cold, dark aircraft, bouncing around through turbulence. You have to kind of know what you're doing, and you have to have some exposure to that. So as long as there's a way to maintain skill competency, I think that it's okay. But I agree with your point, Dave. I think that having that clinical background would definitely, if nothing else, would make a stronger candidate for the transport environment.
I agree. I think you need to have something, like you either need to have pretty robust transport experience as an RN or ICU critical care experience as an NP. To Jake's point, like, can you do it as a new grad? Yes. Like a handful of us handful have been successful. We've also seen a lot of new grads wash out. It's just such a huge mind shift and environment change if you haven't done one or the other. Those are two very hard things to overcome when you're transitioning to a provider, and to have to do them both together at the same time, new role, new environment, it's just exponentially challenging. So like I mentioned, I'm having some trouble staffing for PNPs, or like, recruiting as we're growing this team, because we're trying to do the NP model, but also grow, add shifts, all that kind of stuff. So it's happening all kind of at once. So they've had some newer PNPs, and one of the kind of resources we've set in place is that the PNPs will share part of their FTE with the PICU. So they will do one shift every pay, or 2 to 3 shifts a month, however we work it out, that they're still rotating through the PICU. And some of them have asked for more time up front and then kind of to taper off later, and then just see how that goes. But that way they can still grow as a clinician, still practice those reps, because the challenge of CCT is always going to be reps. How many, like Jake said, how many reps are you getting in central lines? And then when you got to go do it in a rural setting by yourself, how experienced and capable and confident are you going to be in doing that line if the last time you did it was in school, or during clinical rotation? So I think there's a good model to having some kind of shared FTE within a critical care space within the organization. I think that helps keep people fresh and get those reps and those kinds of things. Someone who loves transport, and I don't want to go staff a shift, I'll be totally honest. So it has to have some good ownership amongst the staff, that they really want it and want to be there. That way it doesn't feel like a punishment, or a clinic, like they're back in school once a pay period. But if they get that investment in themselves and they know that this is going to help them grow as a clinician, I have usually seen it be pretty positive and beneficial.
Yeah, I would just add to what the others have said. If there isn't some sort of skill maintenance or connection to the inpatient world, I think a program that's using NPs, particularly NPs that came to transport as a new NP, you very much run the risk of having a group of clinicians who potentially, multiple years into their NP career, really are not functioning to that full potential as a provider. And you run the risk of basically having very, very well paid flight nurses, which is really what we're trying to, if we're selling ourselves that we're bringing an advanced level of care and a procedural skill set and kind of all these benefits, but we're not actually doing any of it, we're kind of just shooting ourselves in the foot to, kind of air the dirty laundry here. So I think whatever your plan is, to go back to the original question for the students, if you are going to go to transport right out of school, you have to take some ownership as a professional to be developing your skill set, to make sure that you're filling in those gaps that your colleagues who are working in the ICU full time, those gaps are just naturally being filled in. And the reps, I can't overstate enough that, even at a busy transport program, a full-time NP, maybe 200 patient encounters a year, give or take. I mean, depending on how many clinical shifts and flights and everything like that, if you're doing transport full time, if you go to the ICU, you might see that in a month. So, and to Robert and Jacob's points, my personal experience working as an inpatient NP in some different roles, I mean, there were days where you did multiple different procedures, and you go to transport and you might not intubate anybody for a month or longer, or as Robert said, you might not put in a central line for many years, and then the likelihood that you're going to jump in and do that in the heat of the moment, in a stressful situation is probably pretty low. So that would be the only thing that, that I would add to that.
So I agree with every bit of it. One of the things that we've asked our NPs to do is a lot of them pick up extra either in the regional emergency departments, the main emergency department, or the rapid response teams within the hospital, and a few still pick up in the ICU. Other things that we do to worry about skill fade, right? So that's the big thing. We're asking you to do a procedure that you may not do regularly on the aircraft, i.e. central lines or art lines. And so we do a quarterly skills for them. So they have to come in quarterly and show competency of those skills. So they get those sets of reps. Now, granted, some we use on either the cadaver model or we'll have the simulation models. So, you know, the fake arms and that kind of stuff. But it's the muscle memory component of it. And then we do, you know, all of our other skills on top of that. So we try and do that. We have it set where they have to do it once a quarter. So at least if they're not doing it in the transport environment, at least they're still maintaining that muscle memory of doing those skills.
The slide that's up, I want to ask the panel, first of all, if anybody's listening and I get this asked, you're never going to start a program to make money. That should not be the argument, is you could bring in more money. Unless somebody else knows the way, then please share that with me. When we put this publication, Keith, I wish we had known each other more, and I would have certainly included you in this, but these were like the topics that we kind of solidified. We talked about how to bring in money and kind of billing very vaguely, realizing that was important. Reallocating physician time is a big one, you know, offloading some of and my argument would be, rather than calling an ER doctor when you have a neuro problem, I would argue the neuro NP probably knows more about the topic. But anyway, being med control is a good use of the NP. Very low attrition. We're transporting the super sick patients. Robert's argument was to limit the risk exposure. Practicing within your scope, right? It's very hard for a nurse to it's easier for an NP who can intubate in the state of Ohio legally versus when you take an RN, you're kind of, they're actually maybe out of their scope. I got to tell you, like, there's fewer resources needed at the referring or accepting hospital. We had a patient, now I work for university hospitals. I'm an ICU at a regional, but they don't fly with nurse practitioners. This patient was pretty sick. They were GI bleed. I didn't think they needed a central line and all this stuff. But that transport RN really wanted a line, so they felt comfortable. And my argument for the NP model right in that situation was, if I was acting as the scope of an NP in this role, I would just do it if I felt it was needed and not having to like take me out of the ICU seeing my other patients. But these are there is there anything I'm missing here? Are there any other like things that stand out? And this would be mainly for like Robert, Dave, we kind of already talked, but Keith, is there anything I'm missing as far as like, what else does the NP bring to the table?
No, I think you hit that, like the really big high point. So our shift operations center, they help with that reallocation of physician time. So that is the big thing that our triage physicians can actually sit, because our emergency department is always on some type of critical capacity. And so actually utilizing those NPs in our SOC to take admission for the physician, that reduces the time that he's having to take away from actually seeing patients and getting them to where they needed. We have a pretty robust SOP that we have developed for our nurse practitioners, and they have to not just show their clinical competency and fly, but they also have additional things that they have to do. Education and mentorship is one big one. We've got the research bucket in there. We've got where they work with other services, whether it be event medicine, whether they work at our regional hospitals and help out in those things. And then the expanded procedural capabilities also help within all that. So pretty much within our SOP, they're having to do something else other than just show up and fly. They're having to help lead committees. They're having to help do research, publish papers. And so we're really trying to utilize them to the maximum capacity and show their benefit. I think that we've done well thus far. We're just continuing to grow at it.
I think the only thing I'd add to this list that I've seen more out here now is, like I kind of mentioned, some of the throughput changes to the organization. Whether or not, like two of the big struggles I have being, the only tertiary pediatric and neonatal facility is like we have 2 floors of NICU. They are frequently full. So if I can have an NNP out there that, in that, compassionate care example, can limit unnecessary transport, it saves a bed for another patient that we could, meaningfully impact. And then, in the ped side of the house, the PICU, again, frequently full, especially when you start going through larger regional seasonal changes, the enteroviruses and the big things that start to fill up the PICU really quick. Those beds become very valuable, especially as they get fewer and fewer, to send that PNP out to the patient and be able to resuscitate, see the patient, maybe preventive transport if they were resuscitated appropriately and they can follow up tomorrow, or downgrade them to med surg or something like that based on the resuscitation. The impact that transport can have on the valuable resources of the organization, which is usually beds and staffed beds, right? So if you can articulate how the APP model can impact that, again, preventing bordering in the ED and changing and not utilizing ICU beds that we don't necessarily need to. Sometimes I've seen a lot of ED focused clinicians in rural areas that really just need the confidence boost to have someone who knows that specialty stand next to them and say it's going to be okay. Especially the peds patients, where they go out and they really just need a little tune up, and then they could probably go home and get seen in clinic tomorrow morning, and don't need that rotor flight halfway across the state. So that kind of specialty care brought to the patient, I think, can really, it seems like kind of like an oxymoron, because we're trying to advance the level of transport to prevent transport, but that is often what is needed and beneficial to the organization.
And I think the other thing too, kind of dovetailing on that, Rob, is sometimes, in the triage capacity, one of the other things that was helpful, when I worked at Cleveland Clinic with their model, having the flight NP or the flight NP working in the e-hospital, kind of working as that triage. So when an interfacility request would come in, the coordinators would get the background information on the patient and then triage that with the nurse practitioner to make sure that the right resource is being sent for that patient. And, if not, because obviously, a sending facility is going to be like, oh yeah, we'll send we have a paramedic team here, we'll just send them, or we want flight for this patient, and sometimes that doesn't align with what the patient actually needs. And having that acumen to be able to say, that doesn't sound right, hold on a second, but then also being able to have that provider to provider conversation. Good, bad, or indifferently, I think there's a different level of respect when a nurse practitioner is able to call the referring physician and PPA and have that provider level conversation to say, hey, I have a concern about this. You're asking to send the patient this way. This is what I'm hearing. What am I missing? And those types of things. And there's definitely been times that I personally have upgraded or downgraded a transport request based on those conversations. And I have, going back to your stories to tell, nursing administration, like there are definitely times when we have chosen to ask the referring facility to wait just a few extra minutes for us to send one of our critical care ground assets where they were going to send by paramedic ALS ambulance. And that patient like floridly decompensated in transport. But luckily, now I, as the triage officer, know about that patient. I'm now in the role of the medical control officer. I know this patient. I've looked into their chart a little bit. So when the nurse from the ground unit calls me and says, hey, this is what's going on, I have the background. I know that patient. And now we can start treating that patient together, even though I'm not even physically on that unit. And we can collaborate and improve that patient's care, which may not have happened in a different system. So I think that's another big role too, is not only sending the clinicians to the patient, but also having the clinicians, the nurse practitioners oversee that system and help with that resource allocation. Are we going to send an ambulance all the way out here for this patient? Can we send a patient by rotor? Can we, they're asking for a critical care team for this patient that probably could go with an ALS team. Why are we sending our team out there for that patient? I think some of that also can help when you look at a systems level perspective and you're trying to allocate the scarce resource that is critical care transport and make sure that the right care gets to the right patient at the right time.
I agree. Raquel, why don't you ask your question? Dave Holloway is going to answer it, but go ahead, Raquel.
So my question was to potentially find something for publication and finding how APRNs bring that added value to certain scenarios. So it's going to be more of those off protocol cases that they partake in versus something where an RN medic crew can just follow the protocol and safely transport the patient, and seeing if there's any certain scenarios that seem to occur more frequently that might be able to be a comparison point.
Sure, yeah. Great question. So I think you could look at this as, if you take the whole population of patients who are getting transported, you kind of have these patients who need that upfront resuscitation. So some of the patients that Robert was talking about, is in a rural outlying facility, low resources. I think those patients certainly can benefit from a provider who is experienced and tenured in running resuscitations and bring that to the patient's bedside. Not saying that a non advanced practice crew can't do that, but Robert had many examples of sending an experienced pediatric or neonatal NP out certainly has its benefits. I think you have this middle range group of patients who are those people who have been stabilized at a referring facility, for example, with what I would consider kind of low to moderate interventions. The patient got intubated, they're on kind of maybe relatively standard vent settings, maybe they're stabilized hemodynamically with a low to moderate dose of one vasopressor. They've kind of declared themselves and their trajectory is well known. I think those patient populations arguably are better served or maybe equally served by a non-NP transport program because I don't know that you're bringing much to the table at that point. I think there's also kind of the upper third of patients who are already at what I would consider tertiary care facilities, who have more advanced therapies already ongoing, who then need transferred to a specialty center or a quaternary center for kind of advanced heart failure, advanced lung failure, congenital heart, specialized neuro, things like that, where the complexity of the patient and the therapies that are already ongoing are so intertwined that writing a protocol to try to detangle the complexities of that patient is going to be next to impossible. And I would use examples of the post-cardiotomy cardiogenic shock patients. So patients who have already been to the operating room, maybe couldn't separate from bypass for whatever reason. They're now on, some sort of mechanical support, often VA ECMO. Their chest might be open, multiple chest tubes, may be receiving external pacing with pacing wires or epicardial wires, may be requiring inhaled pulmonary vasodilators, may be bleeding and have a coagulopathy, also have a metabolic acidosis with an acute kidney injury, and the patient's receiving some concoction of vasoactive infusions, may have multiple invasive lines, potentially a second mechanical device like an Impella or a balloon pump. I think those types of patients, or patients that are similar to that, it is, I would argue, impossible to write a protocol for that. And I think that is where sometimes we have seen at our institutions, the non-advanced practice teams have attempted to move these patients, and either the patients have arrived in pretty bad condition, or they weren't able to be moved at all. And it usually because the patient became unstable. And I think sometimes that is due to a crew trying to manage each individual thread of that patient's complexity in isolation. And I would argue that when you do that, you're kind of asking for the patient to get unstable and have a bad outcome. So granted, I think those patients are somewhat low volume depending on your center and your transport program. But if your transport program and your center is going to invest in accepting those patients to offer potentially advanced levels of therapies once the patient gets there, investing in a transport system that can kind of support that hub and spoke model to bring those patients to you. I would argue that I think that is probably one of the best uses of the advanced practice model.
I agree.
Thank you.
Sure. Does that help answer your question, Raquel?
Yes, it does. Thank you.
Great.
I think Dr. Grabowski was hoping to hop on as well for this.
Oh, I was just replying. I could answer Tony's question, but yeah, I agree with Dave. I think in my realm, it tends to be a lot of the mixed problems and the tech dependent kids and stuff like that right now that I see a lot of issues with. We had a crew out the other day for a kid who had a history of viral prodrome, was clinically dehydrated, asthma exacerbation, became severe and became status asthmaticus. And then during initial eval began having seizures and then had status epilepticus on top of that. And by the time our team got out there, the metabolic derangements were pretty severe. So to write a protocol to be prepared for that type of patient and to manage them as aggressively as they need to be is unlikely. Tony's question I saw were challenges with the sharing of an FTE model. So I'm going through some of that right now. The biggest challenges I have are two, which one is competencies. So if you're in a shared FTE structure, like you're sharing with the ICU, they need to maintain competencies in the ICU and competencies with me. So that's including staff meetings and sim labs and credentialing things and all those other components, simulations, everything, right? So, and they have to do that in the ICU as well. And they all have their own sims, their own skill stays and stuff like that. So it becomes burdensome for a lot of individuals to kind of keep track of all of those extras. But it's kind of what just has to be done. And then the other thing is more administrative, like who fully owns the FTE, who's going to do the evals. If they, my APPs have a contract with med staff that they have, X% of their hours are non-desirable. So that's like after 5 p.m. or whatnot, or on weekends and such. And who's gonna benefit from the non-desirable hours? Are they gonna do nights and weekends in the ICU? Or are they gonna do nights and weekends with me? Are we gonna share that? If they are on a every third weekend, how does that work with what department they're in? Those kinds of things can be just annoying. They're easy to work through. You just have to be proactive about it. Because if you're not, then it will come up at some point when it's inconvenient. But those are usually the only real challenges I've had is just competencies and then the scheduling and benefits component.
We run into that same thing with our residents that fly with us, and it's getting them to adhere to, hey, show up. You've got to show up for case conference. You've got to show up for safety day. You've got to show up for the skills labs to work with the colleagues. So we run into that same thing with our residents. Our NPs, they're all employed full time with us, and they will. We've got a lot of workaholics, as I like to call them, that will volunteer to pick up extra, either the rapid response or in the ERs. We have a few that still do in the ICUs, but the vast majority of them will volunteer to pick up. But it enhances their skills when they are doing the extra stuff. But we can't sit there and say, hey, you have to work X amount of shifts within the ICU or within the ER. Now, what we have done is said, hey, within our SOP, you have to do these additional things. And most of them want to do those additional things. So it works out pretty well. But I can see how it can definitely be a challenge if you're going to do a split FTE. The big thing is who owns it, and who owns it from the competency side of the house is really the big thing.
Monica, go ahead and ask your question. I think it's a great question.
Just from a practical perspective, I was asking how the schedule works when you're utilized in like the transfer center, like on your schedule. For example, are you working 2 12s on the flight line and 1 12 in the transfer center? And during that time, is that when you're providing EMS telehealth services? And kind of the same question going back to the schedule with working in the EICU as well.
So I can speak for the Vanderbilt side when we use our shift operations center, which is basically which is part of our transfer center. They schedule themselves. The way that we have it set up is most of them will do a 24 on the flight side, and then they'll do 2 8-hour shifts or a 16-hour shift working in our transfer center, doing the acceptance and providing the information needed to our dispatch as well as our transport teams.
Keith, when they take the call, do they also choose the level of transport, ground versus air?
So they don't, because of the EMTALA and the way that it's set up in the state is that the referring physician gets to choose. Now, what they do offer is say, hey, based on what you're telling me, this doesn't necessarily meet the flight. We have a ground ALS team that may be able to help, or we have, hey, our flight team, our closest flight team is out. Maybe critical care ground would be better utilized. They still have to leave it up to the referring physician. However, they do offer their insight to this and say, or, hey, we have an aircraft that is X minutes away, and we can go ahead and launch that aircraft while we're having this phone call. If you feel that this is how I feel, but if this is what you choose, we can help facilitate that. And so that way we're not necessarily putting pressure on them to say, absolutely, you have to do this, because it is ultimately their decision. But we are offering our clinical and transport expertise to say, it might be in the patient's best interest to do this versus this.
David, similarly at the Cleveland Clinic, correct?
Yeah, so just I think there was a question about the EICU and flight shifts. So our NPs work, it would be 24 clinical shifts in an 8-week schedule, and also take 4 24-hour call periods in an 8-week schedule. Of those 24 clinical shifts, I would say ballpark 4 to 6 of them are in EICU. The rest are doing transport. Those, sometimes they're all in the same week or so. Sometimes they're just kind of sporadically sprinkled in there throughout those 8 weeks, just depending on how the rest of the schedule looks.
Well, I want to leave this up to Jacob, Keith, Dave, and Robert. I have 8 very generic questions that we could get into. We could wrap it up. Because I know you guys may have other things planned, so I'll leave it up to you. Or if you have something planned, this is an opportunity to just sign off. Otherwise, I'll just get into them. And this is kind of a discussion. If you guys have questions for each other, have at it. So for those of you who have helped develop or expand NP roles within your programs, what advice would you give to others looking to do the same? And I think, you know, Lanika is out there in San Diego who has ICU experience and flight experience. My first piece of advice would be whoever's doing it has got to be on top of a master clinician and willing to work. Because you're going to kind of like set the tone for what the expectation would be. So that would kind of be my piece of advice. And I think you, Lanika, are the perfect person to do that if you can get buy-in. And I'm happy to help. And I'm sure Keith, Dave, and Robert would also be happy to help and help get those types of things started.
I'll say one other thing to add to that is your medical director for your program has to have buy-in. And I think having those discussions early with your medical director of your program helps immensely, because once you get buy-in from that, then you can help leverage from the physician side to help with administration and say, this is the real true value add, and this is why we need to do that. And if your medical director's on board, it helps support that even more so.
Yeah, I agree. The medical direction piece is going to be big, because you're going to be adding potentially a new specialty for credentialing. So you'll need a medical physician to back you for med staff. And then always good to have an executive sponsor of some kind. So a VP or above that's going to back your project. They'll let you in on the things that are valued at the organization and things to highlight, and they'll help you through that process. So if you can get like a VP or a CNO plus your med director is on board with it, you're looking pretty good. Some of it's going to depend on how your operations is structured. You know, if you're in a traditional model or a hybrid model, and who's bearing a lot of the financial burden for your changes. Those are big things to consider. It's a lot easier to make those changes in a traditional model versus like if you're in a hybrid model with a program vendor. You're really fronting a lot more money for not a lot of gain unless you can really tell the story really well. Which you can. There's a way to do it. It's just more of a challenge, I feel like. But the other piece I would give is just have a really solid plan for who you're going to hire for the role, what it's going to look like, what resources you have in place for them. If you have a system APP director, that's great. Make sure you know how they're going to fall under them. Are they going to dual report under med staff and nursing? Those kinds of things. Having a place for them to go, and who's going to train them how to do the job. So, you know, hiring a bunch of NPs and then asking the nurses on the transport team to train them to do their job is not going to set them up for success. So how is that going to happen? Usually it's going to start with 1, and 1's going to build 2, and 2's going to build the 4. Like it's going to, you can't turnkey it tomorrow and add 6 people to your staff. And then my like interpersonal relationship kind of building is making sure you don't alienate the staff that you're augmenting, and make sure you have a really good story and able to say the why and the benefit and not undermine the current individuals doing the role, and really focus on the things we can add and frame them in such a light that it's not detracting from what they've accomplished and what they've already provided, because it's hard when you bring in a role to say, we want to do better. Well, that implicitly makes it sound like you're saying we're not doing good enough now, right? And so you may be meeting or exceeding industry standards, but we just want to add that extra capability. So highlighting those things, I think, makes it more palatable to the group that's going to sit there. And if at all possible, if you can do it during a time of growth or during a time of deficit, that's great. Because the other answer or question you're going to get is, well, which one of us are you firing to get these NPs in here? Oh, well, we're going to do it through attrition, or we're going to do it when we open this new base. Thinking through a lot of those communication pieces, it will really help you with getting buy-in from your team as well.
Yeah, I'd agree with everything that Keith and Robert said. I think the candidate selection is absolutely crucial. You know, you're going to have to be able to pick good clinicians, master clinicians who have the street cred behind them. But you're also going to have to hire people who have those interpersonal skills, who are not going to be abrasive when this type of model is rolled out. So that kind of helps get you started. Once you're up and running, my advice would be that if there are fissures developing in your program, whether that be clinical, behavioral, interpersonal, whatever they may be, identify and address them right away. Those types of problems are not going to get better on their own. So if you have an NP who is just not really playing well in the sandbox, address that right away, because that has the potential to really just destroy all the progress that you've made. So that would be my kind of one grain of advice there.
Would you guys also agree? My opinion is that the nurse practitioner also needs to be able to, I'm sure Keith would agree, I'm guessing, but you can't just sit there and say, do this, do this, do this, do this to your crew. You have to be an integral part of the hands-on. You can turn on the vent, you can change the pumps, you can do everything the nurse can do, but you bring clinical knowledge.
Agree.
Absolutely.
So you got to be a good flight nurse before you can be a good flight NP. Is that what you're saying?
That's what I'm saying. I'm saying it's going to fail if you go in there and think you're going to, you do this, this, and this. It's just, you have to be hands-on. You have to know their job like they know their job. And then you bring another level.
Help carry the bags.
Yeah.
Can't
Right.
wear the white coat at the foot of the bed over your flight suit.
Right.
Right.
Which is why we have them fly as a nurse for the
Yeah.
first year before we do that. So they have that technical competency on top of their clinical competency. So they understand and they've worked side by side with the individuals they're flying with.
All right, Robert. Hey, look me up when you're in town. Thank you for stopping. I appreciate it. I know you have other things to do.
No problem. I appreciate the invite.
Thank
If
you.
anything comes up for me, just shoot them my way. I'm
All
happy
right.
to reach out to anybody who needs help.
All right.
Thanks, guys.
Yeah.
See ya. We're nearing the end. Could each of you describe the specific scope of practice for NPs within your critical care transport? I think we've talked about this. Basically, the NPs on all these programs are autonomous. There's protocols to guide them, but they don't have to follow them. Am I correct?
Yeah. So for us, there's protocols, and then they can step outside, but they have to have a valid reason, right? So it's not just, I want to be a cowboy, right? I have to show from a clinical perspective of why I added this. And then, you know, we've always said, load the boat. So if you need to, you can call medical control and say, hey, this is what I'm thinking. This is what I want to add. Just want to talk to someone else about it. We encourage that as well. So that way we understand that they can operate within the scope of their practice to the maximum that they can. But sometimes it's nice to have that additional resource of saying, let me check with the physician that is in the emergency department and make sure that I'm on the right track and I'm seeing things and so they're able to explain the clinical situation and the thought of, like, I would like to do this, this, and this. And so we've got in their autonomy, they've got that ability to do that as well.
I would just add to what Keith was saying. I think for us specifically in our institution, most of our advanced practice critical care roles are siloed in a specialty ICU or even a semi-specialty ICU. Our NPs have the opportunity to care for a wide variety of patients, all the way from pre-hospital scene trauma to mechanical circulatory support to some pediatrics to OB. So I think that is probably what differs the most for us at our program compared to other roles within our system.
What specific training and competency assessments are required for NPs entering critical care transport in your programs? I think we've talked about this. I tell students in an ideal world, you have both the inpatient and transport experience, and you can mesh them together and you're ready to go. Otherwise, you need one or the other. And I think which one is probably debatable. If you want the procedures and the reps, I think the inpatient experience is more crucial, but there is something to learning the transport environment. Any comments? Am I hitting it? If you were picking one, this is a subjective, just a question. Would you rather have somebody with flight experience or ICU/ER nurse practitioner experience, understanding that ideally they had both? Or am I putting you on the spot? You can say I'd take the fifth as well.
I think each one of them lend their own nuances. If you've got transport experience, there may be sets and reps of things that you haven't experienced as someone that comes from the ICU. Someone that comes from the ICU has unlimited resources or a lot of resources at hand that you don't necessarily have in the transport arena. So I think each one of them come with their own set of pluses and minuses, for lack of better terminology. So ideally, it'd be great to have both. And I don't know that you can definitely say like one over the other, because they do bring their differences. So I know that didn't answer the question, but I think it expanded more on it of like what can be the challenges of both, right?
Yeah, that's a good point too, because you could be in an ICU at an academic center, and if on that ICU, the NP really doesn't do much, that's not very helpful. So it's, yeah. Jacob, you got any thoughts there? If you were
Yeah.
picking one.
I think that, kind of to Keith's point is both have ups or downs. I think you just have to look at the individual candidate and try to figure out what their background actually is. Similarly, you can have a flight nurse who is at a, lower performing or lower volume location, or you can have that ICU NP who's at a very, low acuity, not every ICU is built the same. A small community hospital might have an ICU, but then that patient gets flown into the big academic center and they're like step down status, right? So I think it just depends on who that person is. The flight nurse, you're probably teaching them more higher level clinical thinking. And as we just talked about before with the clinical practice model, there still may be an opportunity to have them get some practice time in the ICU. Maybe it's part of their orientation. And then the experienced ICU NP, you're trying to teach them how to take all those skills and knowledge that they have amassed and now transfer it into a phone booth sized, aluminum box and try to figure out how to do everything they want to do with, the 3 tools they have available to them on shift. So I think that, they both have their ups and downs. And I think it just is going to depend on the individual clinician and their adaptability to whatever the gap is in their practice. So.
At the risk of ruffling some feathers, if I had to choose one side of the fence based on looking back of, my journey, I would pick the experienced critical care NP. Only because, especially if you're trying to build or expand a program and you're making the argument of the NP model, I personally think it's going to be a little bit easier to immediately start delivering that advanced practice model of care with an experienced critical care provider, particularly if they have a lot of those procedural and patient encounter reps under their belt. Again, at the risk of airing the dirty laundry, sometimes we tout well, we can do central lines, we can do arterial lines, we can intubate, we can put chest tubes, all this other stuff. And when you actually start whittling down the actual numbers, they're fairly low. And I would argue that those numbers would probably be higher if we had experienced critical care providers who are very comfortable doing those procedures regardless of the environment. So certainly I think the transport experience is helpful. But I think if you're looking to push an advanced practice model, advanced practice experience, I personally think would carry more weight. And that's coming from somebody who started as a transport NP, worked in the ICU, and came back to transport. I was really blown away at what I was missing by not starting in the ICU.
I agree with that, Dave. I went nurse to flight NP, like flight nurse to flight NP. And you get by, you function, you feel like you provide another level. But once you're in the ICU and you're doing lines all the time and you're intubating a couple times a month and you're seeing all these critically ill patients, several of them at the same time, I feel like the downstream vision changes of where this patient's going, and then the procedure, I was intimidated when I had to do a central line as an NP without the reps, but once you get the reps, it's like, all right, whatever, a couple months later you miss. So my advice, I would choose the ICU clinician as well, but I would also choose a flight, one of the two for sure, but I think the ICU experience brings a little more. All right, I think we'll ask this question and then we'll call it, we'll wrap up. Can you guys share any data or examples that demonstrate, or it could be a case study, whatever, the positive impact that NPs have had on patient outcomes in your transport settings?
I think this is the exact question that we and perhaps this is more of a we than anything. With the backing of the emergency critical care transport center at Case. I think this is what we need. This is where the data is, or this I think is the lack of data, empirical data, published data on this. There's been a couple of things. I know Dr. Reamer has published, some things on this, and other folks from the Cleveland area have published some smaller case studies. But I think this is exactly what we need to help show the value add of this model, because right now I think most of the value add is anecdotal and hypothetical. I think those of us who do this are absolutely in agreement that this is something that is a valuable model. But at the end of the day, I think this question here, I think, is what we need to focus on next to get this, to really delineate what that value add is. So that's my thoughts on it. I don't have the empirical data, but I think that it's probably there and we need to figure out a good way to capture it.
Yeah, and I think that you are 100% correct, but how do you capture it? We can't do a blinded, double, randomized study. It's just, that's the intangible. What we have been able to prove is the value add from an educational standpoint and anecdotal data from our providers doing surveys, or our crew members doing surveys. Did you feel more confident that you were able to help manage a patient because you had a NP flying with you. And we've been able to prove that data. And we've been able to prove data utilizing our ultrasound and how we were utilizing our nurse practitioners to help advance ultrasound and get the sets and reps for the other crew members, and basically use that model for them to teach you. So we've got some published papers to show how that stuff has been beneficial. It's just when you look at the patient outcomes, how can we say that, yes, they were managed better, because every patient's individualized, and it's, we don't do enough of the transports to do that randomized controlled study and say, all right, this is what you're going to get versus this is what you're going to get, and see if the outcomes are different, just because every patient is different.
So research methodology aside, because it would be hard to do any kind of randomized trial because you can't prove an outcome. Just while we have everybody here, all the experts here, is there anything in your mind that we could use as some sort of objective endpoint? Because, no matter the trial you do, we need this endpoint that's going to prove either non-inferiority or superiority. Because I think initially the selling point is billing. You can bill, you can educate, you can do all these things. But if one was to embark on some sort of objective trial, or just looking for an actual data point, is there anything that anybody can think of? You can't use mortality, couldn't really use ICU length of stay. You could use like PF ratio, number of vasopressors utilized, Schweikert's triage tool, something like that. But while we have you guys here, is there anything you can think of that we might be able to use?
I mean, why couldn't we use length of stay or mortality? And to be fair, at the end of the day, it might be a negative trial, but I think the data is still data. Maybe it is initial resource allocation, right? There's some of those trials that are looking at, like the TXA trials, like, oh, they got 5 less units of blood, and maybe there was no mortality difference, but 5 less units of blood across. And granted, this was certainly a drug study, not a provider study, but like 5 fewer units of blood per patient that comes into a trauma center over a number. You take that incremental gain and you look at the cost savings. Maybe it is ICU length of stay, and maybe it's only an average of I don't know, 0.2 days per patient. But you take that and you multiply that across all the patients that are coming into the system or that you're transporting, and you can start to see some amount of incremental gain there. So maybe it is mortality, maybe it is length of stay, maybe it is resource allocation or vasopressor need or procedure requirement at the receiving or those types of things. And I think some of our programs may even have the opportunity to compare. It's a little muddier when you're comparing, like, my program runs with all NPs all the time, and we're going to compare our data against the neighboring program that uses nurses and paramedics. Well, then you run the issue of like protocol variability and all those other things. But then you have some programs that have perhaps the natural experience. Correct me if I'm wrong on this one, but I believe Keith, is Vanderbilt still kind of like, you don't necessarily always have an NP on every single aircraft, correct? That's kind of what the staffing shows.
That's correct. And one of the things I think to go along with kind of Jacob, your part is talk about underutilization of resources versus overutilization of resources. And was the nurse practitioner able to utilize the appropriate resources without under or overutilization, as well as were the correct alerts sent in? So was this leveled? So we do our own trauma leveling. So was this an appropriate levelization of a level 1 trauma versus a level 2 trauma? And then you can randomize those, or not necessarily randomize those, but you can look at, did the NP do it better than the other staff? And the STEMI alerts, the stroke alerts, burn alerts, were there proper utilization? Because if you have a crew member that's constantly saying everything is a level 1, that's an overutilization of our resources, right? As opposed to calling it in as a level 2 or a level 3 based on what they're seeing. So I think that might be one approach to look at.
Thank you so much. I think this might be a more philosophical question, but the only thing would be if we have a negative trial, great, you look at the secondary endpoints. And I think that that's where the benefit will show is not necessarily because, transport's so heterogeneous, will you really show a mortality benefit, especially at, a 0.05 level or something like that. You have to have a massive sample size. But if we have a negative trial, does that are we shooting ourselves in the foot down the road? Because now we've done a trial, we have nothing that shows a benefit. So maybe we don't do a trial and we just rely on these anecdotal, the education, the billing, the advanced level of care for these, the certain cohort of patients that's on mechanical circulatory support or inhaled pulmonary vasodilators, whatever, the sickest of the sick. And maybe it's just program specific, but really good to hear your guys' thoughts. Thank you so much.
I think just one thing to add, and this really isn't a transport patient specific endpoint, but I would be curious to look at kind of as a sidebar to what Keith mentioned, appropriate utilization of resources on arrival, particularly for patients who are being transferred into a tertiary or quaternary ICU. And where I'm going with this is, if you guys can imagine, 10 a.m. in a medical ICU, academic rounds are going on, kind of the daily care plans are being implemented, and suddenly a high acuity patient arrives who needs intubated, lined, and a lot of resources. That's going to consume that nursing staff, that respiratory staff, that provider and physician staff away from the rest of the unit and really disrupts that workflow for the day. So I think it would be interesting to look at if a patient arrives from an APP-led crew who maybe already has these interventions done, is dialed in a little bit, does that reduce those resources needed on arrival to stabilize that patient so that the flow and the resources for the rest of that unit kind of go on as planned, or at least are not as disrupted as they otherwise would be. We see that a lot sometimes. We bring a patient into one of the ICUs, and if there's a lot going on and you add more stimulus and another high acuity patient to that, things get pretty messy quickly. And versus if you bring in a patient who already has a central line, already has an art line, already is intubated if needed, maybe their sedation and vasoactive plan is kind of slimmed down and squared away, where that patient kind of just gets moved over to the bed, they're already on appropriate vent settings, appropriate tidal volume for their ideal body weight, the RT plugs that into the ventilator, the nurses swap the drips over, whatnot, they already have lines. Well, the resource consumption is kind of slowed down there at that point. So I think it would be interesting to look at that.
Well, Henry, Lanika, and Raquel, do you have any other questions? Oh, guys, I think we're good. I think there's nothing from the chat. I really appreciate your time. I know you're all are busy. So thank you for showing up.
Thank you, everybody.
Yep. Thanks, everyone.
guys.
Thanks,
Thank
everybody.
you.
Thanks, y'all.
Thanks, David, for putting this together, and I'm happy to help if anybody needs any help.
Have a great day.
All right.